Welcome to the second in our series of webinars addressing the major changes for the 2021 Office E&M coding, Part 2, Implementation Tips. Next slide, please. So we're using the GoToWebinar format. All of your lines are muted. You can type your questions in the Q&A area, and if you don't have a Q&A box on your version of this product, then you can type them in the chat box. You can go to the download handouts area to get the MDM grid if you'd like to use it while we work through some of these cases tonight. Or you can download our prior webinar or the PDF on E&M changes, and you can also see the frequently asked questions that have been uploaded since our last webinar, along with a number of good resources that are available for those of you who are interested in exploring E&M coding on another level. Next slide, please. So our speakers for this evening are Dr. Megan McNally, a surgical oncologist and assistant clinical professor of the Department of Surgery at the University of Missouri, Kansas City School of Medicine. Jayme Lieberman, assistant clinical professor and vice chair of the Department of Surgery at Lehigh Valley Health Network, Hazleton Campus, University of South Florida, Morsani College of Medicine in Allentown, Pennsylvania, and he is an acute care trauma general surgeon. Dr. Don Selzer, who is associate professor and the chief of division of surgery at Indiana University School of Medicine in Indianapolis, and general surgery and minimally invasive surgeon. And I am Linda Barney from Dayton, Ohio. Next slide. So this evening, what we hope to achieve is to review some of the changes that have been made to the Office Outpatient E&M coding guidelines, with some specific emphasis on the levels and elements of medical decision making. You again have the opportunity to download the AMA MDM table, which will be helpful as we work through things. The next objective is to apply new medical decision-making guidelines to office and outpatient visits for common surgical problems. As noted, hernias, gallbladder, colon cancer, trauma, and breast cancer. What we want folks to understand is this is not meant to be scripted templates to use for your own documentation, but more of a way for you to focus your thinking on how do I take all this new information and all these changes in the E&M coding structure, figure out a way that I can import that into my practice, and how I can formulate a way where I can come up with some compliant documentation that reflects the new work that you're doing. We also want to review how to choose medical decision making or time for reporting, how to count and report total time on the day of an E&M encounter, and how and when to report prolonged services. Just a reminder to utilize the Q&A function on the webinar site. We hope to gather as many questions as possible in our chat box so that we can come up with another frequently asked question document that we can post on the website so that we can keep people updated. And it helps us to share among each other problems that you're having and tips that you may have come up with at your own institutions that will be helpful to your colleagues. Next slide, please. So just for a reminder, for those of you who may not have participated in the first webinar, which is available on the website, These codes are specifically looking at what's in the left lower quadrant box, the new and established office space outpatient codes. We are still in that period where we have two sets of guidelines that we have to deal with, because all of the other E&M visits not furnished in the office and outpatient setting that are listed in the right-hand bottom of the slide are not included in these current guidelines. So all your outpatient office visits are included, but outpatient consultations and emergency room department visits aren't. All the hospital inpatient and observation services, home care, nursing facilities, those things are yet to be resolved. So you have to, in your mind, keep track of two completely different coding structures. All of those other things have the old coding structure, and the new ones are the only ones that apply to what we're talking about this evening. The other codes are working their way through the CPT RVU process. So in time, hopefully we'll have all of these codes under the same structure, and it won't be as painful for your brain to be working in two different playgrounds. Next slide, please. So we talked about this previously, and this is a busy slide, but unfortunately these elements of medical decision making are fairly complex. And as you can tell from this slide, this particular slide looks at CPT code 99204 and 214. Remember, these medical decision-making guidelines apply to the new and established patient service levels. You have your level of medical decision-making that's based on 2 out of the 3 elements, and that's the most important thing to remember. Although there are 3 elements that we're going to be discussing, in order to meet criteria for a given level of medical decision-making, in this case, moderate, you only need to meet 2 of the 3 elements. So across the top column, across the top line, you see element number 1, which is number and complexity of problems addressed. Element number 2 is the amount and or complexity of data to be reviewed and analyzed. And then element number 3 is the risk of complications and or morbidity of patient management. So under element number 1, we're talking about problems addressed. So just because the person has a million problems or comorbidities, if you're not really addressing it at this particular encounter, it doesn't really count so much. Under number 2, similarly, it's not just every piece of data that you can possibly get your hands on, it's the data to be reviewed and analyzed based on this given encounter. So this problem that's being presented, it doesn't have to be a diagnosis, it can be a number of different things. That problem associated with the data that is relative to that, and then the risk that's relative to the particular patient that you're managing. So beyond that, under each of the elements, particularly under the data element, there are a number of categories. So you have the 2 out of 3 elements that you have to achieve to reach the level of medical decision making that you're choosing. And then you have these data elements in categories. So there are 3 categories and a number of requirements within the categories that you have to meet. Test documents and independent historian for category 1, independent interpretation of tests, category 2, and the discussion or management of test interpretation, category 3. So you can see by the little bubbles there, our example is a woman with an abnormal mammogram, which is an undiagnosed new problem with uncertain prognosis that meets the moderate level for problems. You have reviewing of a mammogram, which meets the independent interpretation of the test. And then you have speaking with another clinician regarding her HER2 news status with pathology, or talking about pre-op localization with radiology. A number of different things will fit into that category. Next slide, please. So again, we have to remember that the medical decision making will drive documentation. So we have the elements, which are the problems that can be self-limited, chronic or acute, complicated or uncomplicated, and various types of exacerbation of illness or side effects of treatment. Under the data element, you have to somehow document in your charting that you are doing these things. I reviewed the following unique tests, reports, or notes. That you had an independent historian available, that you performed an independent interpretation of imaging, and that will require perhaps you adding some information regarding what exactly was your interpretation of doing an independent interpretation. And under those circumstances, it cannot include interpreting something that you can independently bill for. So if you're doing an ultrasound in the office and coding for that ultrasound, you don't get to independently use that category of independent review for something for which there is an existing CPT code. And then discussing your management with an external source, meaning not one of your partners or someone within your same specialty. And then element 3, the risk, is itemizing specific procedure risks, in some way elaborating on discussing risks that are relative to that patient because they're morbidly obese, so they have uncontrolled diabetes. You're able to utilize those comorbidities because they are directly affecting the procedure that you are planning to perform for this patient. And then next slide. So we're going to go through some cases and hopefully help you to get some tips on how you can implement this. I think you're up, Don.
Thank you, Dr. Barney. This is Don Selzer, and I would just like to orient everybody because this is going to be a slide or a slide type that you're going to see several times over the course of this presentation. So there are presentations or examples that come from 5 different areas. We're going to start off with abdominal wall hernia. This is the first of 3 different examples using the new E&M coding strategy based upon the 3 different areas in medical decision making that Dr. Barney just discussed. So we'll start with this example, and you'll see that it generally becomes higher level coding and more complex patient care in each of the successive examples when we have multiple examples in each subject matter topic. So we have a 56-year-old female that presented with additional or new areas of pain close to 2 prior incisional hernia repair sites. And the new E&M coding does not prevent the need to document physical exams. So a physical exam is performed and documented, and the surgeon doesn't identify a discrete defect and decides that a CT scan of the abdomen and pelvis is necessary to further evaluate the patient, so orders that. So if you look over this brief clinical history, what you're going to identify is that there's a problem. You're going to identify that there's data that may or may not be reviewed, and then you're going to identify the risk. And so in this scenario, we have the 56-year-old female with pain. The data really hasn't been reviewed yet, so you will find that you don't get a lot of credit for that, but you are ordering a CT scan. Next slide. So if we look specifically at the problem, using the medical decision-making element 1 coding strategy, we can identify that this 56-year-old female who has a new uncomplicated problem of pain near 2 prior incisional hernia sites would lead to justifying a level 3 value for this particular area of medical decision making. Next slide. Now, if we look at data analyzed, we see that really there's a CT scan ordered, but it's not been analyzed yet separately. And even if it were analyzed, it generally isn't going to meet the specific areas that are going to reach the level of a level 3. So in here, it only reaches the level of a level 2, but that's okay. We have one area of medical decision making that is reaching a level 3. We have one that's reaching a level 2. Next slide. And now the final area of evaluation is the evaluation of risk, what we're going to do now with this knowledge, and we're going to order a CT scan. So we have a new acute problem that is fairly uncomplicated. We didn't really evaluate additional data other than our own physical exam, and we're going to order a CT scan, which provides low risk for additional diagnostic testing. So this justifies a level 3 code. Next slide. So our next example is a little bit more complex, and this is going to be an example or a scenario that would justify a level 4 code for a new patient who has an abdominal wall hernia. So this is a patient who had a prior hysterectomy and is being reevaluated now by a different surgeon in a different practice. And this new surgeon evaluates notes from a surgeon that evaluated the patient previously. Also evaluates the actual CT images that were advanced to this surgeon via a radiology cloud and performs his own independent evaluation of those images because the CT scan report isn't available. The particular challenging scenario here is that the patient lacks any health insurance. And so the surgeon discussed with the patient potential methods of mitigating symptoms as she works to obtain adequate insurance coverage to get a CT scan of the abdomen because the surgeon feels that that's necessary. So again, we have a problem, we have data, and we have risk. Next slide. So in this particular scenario, the problem is a 39-year-old female who had a previous surgery and now has what looks like a hernia that's getting worse. So this is a hernia that's been around for a while, but it's now getting worse. So there is an exacerbation or a progression of this hernia. Therefore, that meets the identification or level of coding for problem in the level 4 of a new patient, as we see here on the right side of the slide. Next slide. If we evaluate the data that's being reviewed, we can see that the surgeon here evaluated the CT scan images himself or herself and looked at the note from the previous physician. So in this circumstance, the surgeon is performing the potential need to justify data review that would justify a level 4 or moderate data analysis for this new patient. Next slide. And then finally, in risk, this surgeon is dealing with a scenario where this patient unfortunately doesn't have insurance and as a result is unable to obtain the test that the surgeon feels is justified or necessary to be able to treat the patient. And so this actually identifies this last bullet point in the level 4 category for risk, diagnosis and treatment that is limited by social determinants of health. So in this scenario, the surgeon actually reaches all 3 areas, problem, data, and risk, that justify a level 4 for this patient encounter. Next slide. Finally, the last example in hernia is in the upper level of codings, the level 5 for medical decision making. So there's a lot of history here. This is a 54-year-old obese individual with a history of diabetes, obstructive sleep apnea, and non-alcoholic steatohepatitis, who has a large umbilical hernia that has grown in size. And there's actually skin erosions that are leading to some bleeding that presents the patient to the emergency department. The patient has a hepatologist, and the surgeon is seeing the patient now in their office. And the surgeon has read the hepatology notes and has also evaluated a CT scan images and performed an independent interpretation of those images. The surgeon feels that this patient may require surgery, and the patient also has noted to have a fairly amount of significant ascites within the abdomen. So the surgeon orders a number of laboratory tests and actually reaches out to the hepatologist to discuss the management of this patient. So ultimately, it's clear that the hernia is going to have to be repaired, but this is a very challenging patient with a very specific problem that's going to be very specific to how this hernia is going to have to be managed. And that all impacts ultimately the coding for this patient. So if you look at the problem, we have a 54-year-old individual with a number of health problems, including liver disease with ascites. The surgeon performed a number of data analyses, including review of notes, interpretation of a CT scan, and ordered some laboratory tests. And then we know that a hernia repair is going to be necessary, but the patient's specific health problem, advanced liver disease with ascites, is going to make it more difficult. Next slide. So if we look at the problem, we have this patient who has a umbilical hernia that's been around for a while, but now it's leading to bleeding because of skin erosions that are leading to multiple emergency room presentations. And so this actually is a chronic illness that has a severe exacerbation or progression that's making us consider having to do a surgery on this otherwise very unhealthy patient. Next slide. If you look at the data that's been analyzed, this surgeon did a lot and would have to document all of those things, including physical exam again. And so the surgeon in their note would have to document that they reviewed all of these tests, that they reviewed the notes from the individual provider, the hepatologist, and that they reviewed the CT scan images as well and performed an independent interpretation. As well as this surgeon also discussed the management of this patient with the patient's hepatologist, all on the day of service of interacting with this patient and billing for them. Next slide. And finally, with regard to risk, clearly a hernia repair like this would be considered a major surgical procedure. And because this patient has advanced liver disease and ascites, this is an individual who has a specific identified risk factor that makes a typical umbilical hernia repair more complicated. And that's what justifies the level 5 versus the level 4, where it's simply discussing a major surgical procedure and the usual risks associated with this. This patient's health has a specific identified risk that justifies the higher level within that category. So this surgeon has actually justified level 5 documentation in all 3 areas: problem, data, and risk. Next slide. So we're going to transition now to gallbladder disease or biliary disease. And this is the second of the 5 different topics that we're going to review tonight. We only have one review here because I think you can imagine multiple different ways how this could be less complex or more complex, and how it could justify, now that we've started to review these, a level 3 or a level 5. This in particular is a level 4 example for medical decision making that's going to justify coding for right upper quadrant pain. So we have a 46-year-old patient who has 2 hours of crampy right upper quadrant abdominal pain. Patient seen in the emergency department where a bunch of labs are ordered, and a CT scan of the abdomen and pelvis has also been ordered. The surgeon evaluates the CT images before the report is back, and the surgeon performs an independent evaluation of those or interpretation of those images and notes that there's no significant pathology. So a right upper quadrant ultrasound was ordered by the surgeon. That shows gallstones, but there's no signs of acute cholecystitis. And while all of this is happening, the patient's symptoms are getting better. So the surgeon feels that the patient's going to require a cholecystectomy but it can be performed electively. And so the surgeon discusses with the patient the risks of the surgery and ultimately tells the patient that this will be scheduled through the office and they can expect a phone call. So again, we have a problem, 2 hours of crampy right upper quadrant abdominal pain. We have different data that's been evaluated here, and we have risk. So let's go through these. Next slide. So this is a 46-year-old with 2 hours of crampy abdominal pain. This is an acute, uncomplicated problem. So this only justifies a level 3. Again, I gave an example that this is going to justify a level 4. We only have to justify a level 4 or higher in at least 2 of the 3 areas. So in problems, we don't reach that. Next slide. However, in data, we do. So we have to meet the requirements of at least 2 out of the 3 categories below. And because the surgeon will do these and document them in the note, reviewed the notes of the emergency medicine physician, reviewed test results, and reviewed the ultrasound report, as well as interpreting the CT scan images independently, this surgeon met the documentation actually for a level 5 in data reviewed and analyzed. So this reaches a level 5, whereas the first reached a level 3. Next slide. And the final area is with regard to risk. And the surgeon said that this patient needs a laparoscopic cholecystectomy. This is a straightforward operation in this individual who doesn't have a lot of other health problems. So it's an elective major surgery, and the patient doesn't have any particular risks that would make them unique. So this is level 4. So again, in problem, we was a level 3. In data, it was a level 5. And in risk, it was a level 4. And that all across the board as a result justifies a level 4 for this particular interaction. And with that, I'm going to transfer it over to Dr. McNally for the next example.
Thank you, Dr. Selzer. So my 2 examples will focus on colon cancer, but you could also kind of extrapolate these to other malignancies, similar to how Dr. Selzer described hernias and biliary disease. So my first example will be a level 4, and this is a 65-year-old male presenting after a screening colonoscopy in which an ascending colon cancer was found. The surgeon reviewed the lab tests. His hemoglobin was normal. He had no symptoms. The surgeon reviewed the GI notes and discussed the endoscopy with the gastroenterologist. The pathology was reviewed. The CT scans that were staging of the abdomen and pelvis were reviewed. And so then the patient and the surgeon discussed proceeding with a minimally invasive right hemicolectomy. During that discussion, the risks of the procedure were also discussed. So we have a problem, which is the 65-year-old male with the colon cancer, which is asymptomatic, the data that was reviewed, and the risk associated with the procedure that was recommended. Next slide. So going through our elements again, the first element of problem reaches a level 4 or moderate. This is an undiagnosed new problem with an uncertain prognosis. We know he has colon cancer, but we don't know his ultimate stage. And so the prognosis is currently uncertain. Next slide. The next element, the data review. For a level 4, one of the 3 following categories needs to be met. And with this example, there's actually 2 of the 3 categories that are met, and it meets the level 5 for the data review. In category 1, the tests that were reviewed include the labs and the tumor marker. In category 2 were the independent interpretation of the test or the staging CAT scans. And in category 3, discussion of the management or test interpretation. So the surgeon discussed the endoscopy with the GI endoscopist. Maybe they confirmed the location of the mass or any obstructive features of the mass, something that would affect surgical decision making. Next slide. And then in our final element of risk, this reaches a level 4, which is a moderate risk. The patient is otherwise healthy, they're otherwise asymptomatic. We are deciding to perform an elective major surgery with identified procedure risk factors, but nothing that would increase the risk above normal for this procedure. So although element 1 reaches level 4, element 2 reaches level 5, element 3 also reaches level 4. So the documentation would support the 99204 overall. Next slide. Now looking at another example, And this one is more a level 5 example, again, looking at colon cancer. In this example, it's a 78-year-old obese female. She has comorbidities of coronary artery disease, congestive heart failure, and diabetes. She had iron deficiency anemia that did require a transfusion. And after endoscopy, a sigmoid colon cancer was noted. The surgeon reviewed the staging CAT scan, the CEA, the pathology, and the endoscopy reports. The surgeon also reviewed the primary care physician notes, the GI notes, the medical oncology notes, and the cardiology notes. Then the surgeon discussed the endoscopy with the gastroenterologist. The surgeon then discussed with the patient proceeding with a minimally invasive sigmoid colectomy. The additional risks were also discussed, and then additional discussion around the need for evaluation and optimization and pre-op risk stratification by the cardiologist were also had. And then the surgeon also ordered a preoperative CBC and CMP to reassess the anemia, as well as some other abnormalities that could be seen with the CMP prior to proceeding with surgery. So again, you have your problem of the colon cancer. You have some additional data review in this example than in our prior example. And then the bigger thing with this example is the level of risk. Next slide. So again, in level 1, we now have an acute or chronic illness that poses a threat to life or bodily function. This is a patient who has coronary artery disease and CHF, where anemia can be significantly limiting or can have significant exacerbation of these comorbidities. Next slide. Under our data review, at least 2 out of the 3 categories need to be met. Under category 1, the surgeon reviewed notes from the primary care physician, gastroenterologist, medical oncologist, and cardiologist. Additionally, a CBC and CMP were ordered, and then the CEA and pathology reports were reviewed. Under the independent interpretation of tests, the CT scan and endoscopy were reviewed, and then the management was discussed with both GI and cardiology in order to optimize the patient preoperatively. The cardiologist was looped in on this discussion. Next slide. And then finally, under element 3, the risk category. This is a patient with significant comorbidities, and so those identified patient risk factors increase the risk above what would be typical for this procedure. So this increases the morbidity from this treatment and brings us to the level 5. Next slide. The next 2 slides, I want to focus on some tips that I've done within our electronic health record. Now, we all have different versions, so some of these may be a little bit more specific to the version that I use, as well as some that can be more applicable to other versions. So one of the things that you can do, you can use the EHR to highlight portions of your note, similar to how we did in some of the examples that we've given, and that can facilitate coding. You can use drop-down lists to identify the key portions of your MDM. You can use dot phrases to fill in common phrases. For example, you can create a dot phrase to auto-fill in that you reviewed the CT images and that you agree with the interpretations, or that you disagree with the interpretations and fill in your interpretation. You can use different templates to show what your elements are. So under element 1, you can use a fill-in or a pick list. Under element 2, you can outline each portion of the data that has been reviewed. And under element 3, you can have a fill-in or pick list, or even use a template to show your risks or the comorbidity influence. For example, with my EHR, I actually created a smart list with a dot phrase that goes through each of my elements to show what level of problem I addressed, the data that I reviewed, and then portion of that is a dot phrase with outlining the risk and the risks associated with certain surgeries, as well as the potential influence of comorbidities. Next slide. To further illustrate this, this is kind of a template example where you can have a drop-down list or a smart phrase that has this in there, where you can fill in or pick list part of the assessment and plan to show what the problem is. And it's important also to highlight, especially like in your HPI or maybe in the assessment, some of those features of the problem that can say if this is acute or chronic, if it's progressing. That should all be highlighted in this portion. For element 2, you can highlight which of the following tests that you reviewed, and that can either highlight them or you can leave these little blanks to kind of fill in your template all of the things that you reviewed as part of your data review. And then under element 3, it's nice to come up with a phrase or a dot phrase about what the risks of the certain procedure include. And then again, if the patient has comorbidities that influence their risk, you can add that in there. So for example, you may say the patient's comorbidity of CHF, coronary artery disease, and anemia increase the risks of perioperative cardiopulmonary complications. And you can have that built into your template or to however you document the notes currently to help facilitate creating this documentation to justify the level of coding. It may be a little bit more difficult as we are new in this process with this new version of E&M coding to figure out exactly how things will be audited or how coders will pick up on this. So making it as clear as possible in your documentation to show the work that you've done in order to justify the level of work that you performed is going to be very helpful going forward. And that's the end of my section, so I'm going to pass it off to Dr. Lieberman now.
Thank you, Dr. McNally. We'll get back to the examples. I'll be presenting outpatient established patients in the trauma clinic, 99213 through 215. So for our example, each patient will be similar, but with increasing degrees of severity of injury and comorbidities. So the first patient is a 73-year-old female with a past medical history of COPD who was seen in the ED 7 days prior to your evaluation by your partner for a left fifth rib fracture. She was seen in consultation in the ED by request of the ED physician, and the plan was to discharge the patient home from the ED with instructions for follow-up. And she presents today in your clinic with a pre-ordered interval chest X-ray. She is doing well. She complains of minimal pain with inspiration, but is otherwise stable. She is taking NSAIDs at night to assist with pain control, but otherwise her pain is well managed. She's using an incentive spirometer, and you actually take a look at her chest X-ray and you document that you see a single rib fracture and there's no other issues. You discuss with her the incentive spirometer. You also discuss with her her expected course of recovery, potential for long-term rib pain, the use of her non-prescriptions anti-inflammatories, and an expected return to unrestricted activity. So as has been stated, we have a problem, a 73-year-old female with one rib fracture, data, the chest X-ray, and risk, which is discussion of continued treatment with a spirometer and nonsteroidals. Next slide, please. So the first element, the problem, is a acute uncomplicated illness, or in this case, an injury for this patient. So it qualifies for a level 3. And just to note, and we'll get into this over the next couple of slides, a unique source or a unique provider is defined as a physician or a QHP outside of your specialty or outside of your group. So essentially not your partner. Next slide, please. So the data analyzed in this case actually qualifies for a level 4, as it meets 1 out of 3 categories, which is independent interpretation of tests. You documented that you reviewed the chest X-ray and you documented the findings. Next slide, please. And for risk, it's low. There's low risk of morbidity for a single rib fracture with someone with not a lot of other comorbidities. And this qualifies for a 213. So even though the element 2 supports a 99214, elements 1 and 3 support 99213. So the overall code for this particular scenario is 99213. Next slide, please. Our second patient is slightly more complicated. She is a 73-year-old female again with a past medical history of COPD, emphysema, and tobacco abuse, who was actually hospitalized with 4 rib fractures and an associated small hemothorax. She was seen by the partners in your group while she was hospitalized. She presents at your clinic today with a chest X-ray and a follow-up hemoglobin, and you review all provider notes. You review the hemoglobin, which is normal. You review the chest X-ray and you document that it reveals 4 rib fractures, but there's no evidence of hemothorax and no new issues. The patient does complain of pain with inspiration and while lying flat in bed, but she's otherwise doing well. She does claim that she takes one narcotic pill at night to assist with pain control, but is managed with prescription NSAIDs during the day. She does have a spirometer at home, but does not use it. You counsel her about the use of narcotic pain medication and develop a weaning plan for her. You talk to her about her chest x-ray and intensive spirometry. So again, we have a problem, the 73-year-old female with several rib fractures, data, lab tests and chest x-ray, and risk, prescription drug management. Next slide, please. So for element 1, problems addressed, this is an acute complicated injury. She has several rib fractures. She had a hemothorax, and she has some comorbidities which complicate the patient's situation. So this qualifies for a level 4. Next, please. Data reviewed for element 2 is moderate again. You review the chest x-ray independently and document that you have reviewed it with the 4 rib fractures and no evidence of a continued hemothorax. Next slide, please. And risk is also level 4, 99214, in that you talk to her about her prescription narcotics and her NSAIDs and develop a weaning plan for her. So this patient on all 3 elements qualifies for 99214. Next slide, please. The next patient is a 73-year-old female with past medical history of COPD, emphysema, tobacco abuse, and home oxygen dependency. She was recently hospitalized with a flail chest with 4 ribs and was discharged 4 days ago. While hospitalized, she was seen by the partners in your group. And shortly after she was discharged, she saw her pulmonologist. She came today to your clinic with a chest x-ray and a hemoglobin. You review the pulmonologist's notes and your partner's notes. On exam, the patient appears to be in moderate distress. She's tachypnic and tachycardic. She's hypoxic. She complains of continual pain aggravated by inspiration, and she's taking narcotic pills daily, and it does not control her pain well. She does have a spirometer, but does not use it. You review her chest x-ray. It reveals the flail segment and the hemothorax. The hemoglobin is normal. You call her pulmonologist to discuss the management of the patient. Because of her clinical status and the lack of adequate pain control, you discuss with the patient your recommendations of readmission to the trauma med surg unit, and she agrees. So again, we have a problem, data, and risk. The problem is a 73-year-old female with multiple pulmonary comorbidities and a flail chest with systemic symptoms. The data are the notes, the x-ray and labs, and the discussion with the pulmonologist, and the risk is potential threat to life or bodily function. Next slide, please. So as stated, the problem here is a 73-year-old female with multiple rib fractures and flail chest with continued pain and systemic symptoms. This is an acute injury that poses threat to life, secondary to the fact that she has tachypnea, tachycardia, and hypoxia. So this is a level 5. Next slide, please. For element 2, data reviewed and analyzed. This is also a level 5. You independently interpreted her chest x-ray and documented as such. You call the pulmonologist and talk to him or her about the patient and document as such. And for category 1, even though you review the pulmonologist's notes and you review the hemoglobin, it does not qualify for category 1 because there's only 2 of the 3 met, but nevertheless, it still qualifies as a category 5. Level 5, next slide, please. And last, risk also qualifies for a level 5 code because you discussed and coordinated hospitalization secondary to a high risk of morbidity, secondary to her systemic symptoms. And that concludes my portion. I'll turn it back over to Dr. Barney.
Thanks, Dr. Lieberman. So our patient is a 42-year-old female who presents with a painful asymmetric left breast. Her PCP ordered lab test and indicated that she had a tender swollen left breast for 3 weeks, treated with antibiotics. You independently reviewed the ultrasound ordered by the PCP that indicated some findings suggestive of mastitis or small abscesses, including multiple areas of hypoechoic tissue, and you have concerns that there may be more there than what was officially read. You review her bilateral mammogram from the year prior that shows dense breast tissue with no discrete masses. Her relevant history includes a maternal grandmother with ovarian cancer. You perform a medically appropriate physical exam and history. You note marked breast asymmetry, with the left breast being at least 3 or 4 times larger than the right, with diffuse erythema and skin edema and a large central mass with nipple fixation and multiple firm axillary lymph nodes. You have clinical concern for inflammatory breast cancer, and you discuss this with the patient, as well as a need for tissue diagnosis to direct treatment. You can perform a skin biopsy, needle core biopsy, or axillary lymph node FNA or core biopsy with clip placement, or you can refer them on for that. If you do those procedures in the office, you would need to code this as add 25 modifier for a significant separately identifiable E&M service performed on the same day of your procedure. So your problems are a 42-year-old woman with suspected inflammatory breast cancer. You reviewed her PCP notes and the lab tests that were ordered, and you independently reviewed her ultrasound and mammogram. And your risk is based on your decision regarding further testing and biopsies. Next slide, please. So in terms of the problems addressed, you have an undiagnosed new problem with uncertain prognosis that keeps you in the moderate category. Next slide. In terms of data reviewed, you've reviewed an external note from a unique source, her primary care physician. You've reviewed a lab test, and you've ordered a CMP. Because you are ordering a test, you have to remember that you don't get credit for ordering a test and then reviewing it. So the expectation is you order the CMP, you review the CMP when that information is available, but you don't get accounted twice. And you independently interpret her imaging, which gets you at the level of 99205 because you've met 2 out of the 3 categories, which qualifies for extensive review. Next slide, please. And from the risk category, she's a young, healthy person. You're ordering biopsies with attention to the risks. So there are some risks performed in this red hot mess, inflammatory breast cancer in the office. She has moderate risk of morbidity from her additional diagnostic testing and treatment because she has a significant procedure with an uncertain prognosis. So you've documented elements 1 and 3 to support 99204, and your data is 99205, but you've met 2 of the 3 in the 204 category, so she meets criteria for a moderate level. Next slide, please. So she comes back to see you in follow-up, so it's a 99214 because she's an established patient returning for follow-up now to discuss the results of her recent biopsies and imaging. You update your relevant history and physical exam as it's available, checking your biopsy sites. You review with her pathology that reports an invasive ductal carcinoma, ERPR negative, Ki67 of 70%. You discuss her HER2 new status with the pathologist because it's not back yet on your pathology report and you need that information to guide your treatment. You independently review an MRI that you ordered showing multiple suspicious left axillary lymph nodes, diffuse thickening, generalized breast edema, and this central breast mass. Her right breast is unremarkable. You order a metastatic workup with CT, chest, abdomen, and pelvis. You order genetic counseling because she's young with premenopausal breast cancer and has a family history of ovarian cancer. You speak with plastic surgeon regarding timing of breast surgery and eventual reconstruction. You spend a lot of time explaining to her her treatment options, which will most likely revolve around adjuvant or neoadjuvant chemotherapy first, to be followed by radiation and surgery, and the need for an internal jugular port placement for her therapies. So you have a 42-year-old female with a confirmed diagnosis of inflammatory breast cancer. You've ordered scans, you've reviewed her pathology, you've ordered genetic testing, you independently reviewed her MRI, you discussed her HER2 status with the pathologist, you discuss her status with a medical oncologist, and a plastic surgeon. You map out her further treatment plan. Next slide, please. So she has one undiagnosed new problem. So she's at a level 4 based on what her presenting symptoms are. You now have the diagnosis that it's cancer, but it still has an uncertain prognosis because it's a very aggressive inflammatory breast cancer. Next slide. You met the data elements, as I noted. You reached the level of 5, an extensive review with 2 of the 3 categories. You got the unique review of notes, tests, and ordering of tests. You independently interpreted an MRI. You discussed the management of her care. So that's level 5. Next slide. And on your risk, some would say it's a little bit, it could go either way. You're calling her a 214 because in terms of your particular management, at this point, you're going to put a port in her. She's young and healthy. It is a major surgery with identified patient and procedure risk factors. But for the oncologist who sees her, it might be at a level 5 because they're talking about the dangers of a very aggressive chemotherapy regimen and her highly morbid disease. So you have met 2 elements of 214. Therefore, even though your data elements was a 215, you reached the criteria for 214. Next slide, please. So this last case is an 88-year-old female with dementia in a nursing home who presents with a new left upper outer quadrant breast mass contiguous with a bunch of palpable lymph nodes. She's had a prior CVA and some residual left-sided weakness. She's here with her daughter. When she was able to make her own decision, she clearly identified that she did not want any advanced measures to prolong her life. She has a DNR and a power of attorney for healthcare. On exam, she has this large clinically positive breast cancer with lymph node involvement, a swollen arm, a swollen breast, inability to move her arm. You suspected it's a left axillary tail breast cancer. You've conferenced in her 2 sons from out of state, along with the daughter, to address mom's needs and where we go from here. You will offer her a needle core biopsy because if it's hormone receptor positive, you may be able to put her on an aromatase inhibitor, which will perhaps slow the progression of the disease somewhat. You also discuss palliative care options and pain management, which is her current problem. You discuss the management with her nursing home physician, a palliative care team, and a lymphedema therapist. So in this case, you could report it as a 99205 based on your medical decision making, but you choose to report this based on time. So your records review prior to the visit is 20 minutes, your history and physical exam 30 minutes. You discuss prognosis and treatment options depending on her receptor status and everything involved in palliative care. You do charting and phone conversation with the PCP and palliative care, and you order lymphedema management and an entry pain management. So your total time on the date of encounter is 95 minutes, not including the time for a needle core biopsy if you choose to do that. But remember that total time on the date of encounter includes all activities that you individually perform, except for procedures. That's subtracted. And you then you have a specific time designation for the amount of time at each code level. And this code, since it's extra time, you start moving into the prolonged services category. Next slide. So you meet a moderate level because it's an undiagnosed new problem with uncertain prognosis. Although she has some health problems, they really aren't at the level that you meet the criteria of 5. Next slide. You review, your review is extensive. So you meet criteria of a level 5 for the medical decision making. Again, next slide. And your risk is high because at the end, whether the family decides they want to proceed with any kind of treatment or you choose not to, or you choose to de-escalate care, you get the same credit for the decision not to perform procedures as you do to perform them, especially when you're spending that added time and effort to describe the options and engage the family in selecting the level of care for that patient. Next slide. So just a few brief thoughts about coding for prolonged service. So in terms of time is you have the same levels of new and established patients that you can code for time. You have these specific time ranges that are utilized. When you're billing for prolonged services, you have to meet level 5 in order to use prolonged service, and it's a strict 15-minute code. You have to hit the whole 15 minutes. There's a significant difference though with coding with the HCPCS codes G2212 as opposed to the 99417 CPT code. So with the Medicare-based code, the threshold is at the high level. So 99205, you have to reach the 74-minute threshold before you apply 15 minutes of prolonged service. So you provided 95 minutes. That keeps you within one element of prolonged service. So it's a 99205 plus 1 G2212 prolonged service. So you have to hit the maximum of the time threshold. Next slide. With 99417 for the non-Medicare population, the difference is minimum threshold. So you meet the 60-minute, the lower limit of coding for a 99205. You apply 15 minutes on top of that, and for your 95 minutes of service, you've actually reached 2 elements of prolonged service. So it's a little bit confusing, but right now there are 2 different ways to code based on who your insurer is and who's interpreting the CPT recommendations versus the Medicare HCPCS code. Next slide, please. So when you're billing for time, it is total time of the physician or qualified healthcare professional on the date of encounter. It's both face-to-face and non-face-to-face time. So all of those elements seen on the left, preparing to see the patient, reviewing outside history and physical counseling, education, ordering medications, referring to other providers, documenting, independently interpreting and communicating tests, and care coordination. So time by other staff in the office does not count, and time does not count for any activity that is separately reported. As I said before, like if you perform an ultrasound in the office or you perform a procedure in the office, you have to subtract out that time. You can't use this. Okay, next slide. So here's an example. The patient encounter took 95 minutes today to perform. You describe what exactly you did, discussion regarding prognosis, the range of treatment options, depending on receptor status and palliative care, in a lengthy discussion regarding care options. and charting and phone conversations and ordering your additional services. So you have to document what you've done in the chart. You still have to document, even though there's less, you still have to document how you met that criteria. And everyone needs to be a little bit aware of private payers versus Medicare and what the rules are for documentation and medical necessity and all these things that still contribute to your requirements. Next slide, please. So that's our wrapping up for this evening. This webinar will be available within 24 hours on the website. For more information, you can see the facs.org EM coding site and download any of the additional resources we have available. Lauren Foe, our Senior Advocate for Regulatory Affairs, her email is at the bottom. So if you have any particular things that you're noticing within your practice, you're having denials based on these new services this year, we'd be interested in knowing, and please forward on any questions that you have. We encourage everyone to use the coding hotline, particularly for any new services that you have questions about regarding E&M coding, as well as your surgical procedural coding. We will be back sometime in the summer with early learnings and more frequently asked questions. Thank you for participating this evening, and have a good night.